managing team of BMA, Dr. Rajesh Deshpande sir, Deshpande madam, Bhavan Salve, Sagar Subekar, Chaudhary madam, Jadhav madam, Padmanabh Keskar sir, Narayan Jetwani and Dr. Adkar. And I would like to congratulate Dr. Umarji for his new president venture. The arrangements are really world class. The audio video is very good, and I think I am speaking in one of the international conferences. So thank you very much for the arrangements. Okay, so 2026, what is there in the dish for interventional cardiology? We know that the coronary artery disease is progressing, the metabolic syndrome, which is discussed already, the diabetes prevalence has increased, lifestyle has worsened over the years, and we are dealing with advanced atherosclerosis, be it coronary artery disease, be it stroke, be it peripheral vascular disease. But we are dealing with these problems day in and day out. And what these new advances has helped us to treat our patient in a best way. Let us review that. We are going to review the recent advances in cardiology, understand the advanced diagnostic tools, discuss newer interventional and device-based therapies, and what is the future. So, clinical cardiology has evolved from clinical diagnosis to invasive diagnosis, shift from simple angiography to imaging and physiology, and growth of minimally invasive procedures. Many patients come to us at the age of 40-45, multivessel disease. RCA shows 99% block, left coronary artery disease, main artery disease has shown 70% block, LAD 30%. Patient is just 45-year-old. What are you going to offer to him? Are you going to offer him bypass surgery? Not sure, because neither the patient nor the relatives want it. Because bypass surgery, even though it is a gold standard for multivessel disease, is really not so simple for the patients, and it comes with its own package of infection, package of strokes, packages of dehiscence of the sternum, and those who have undergone the bypass surgery can tell you how not so simple it is. We know that cardiovascular disease is the biggest burden nowadays we are facing. It's a leading cause of global mortality, rising incidence due to lifestyle changes, and we need advanced and precise treatment. So, when patient come to me with multivessel disease or advanced coronary artery disease, say he is 50-year-old, diabetes for last 4 years, multivessel disease, calcium score is high. I will ask myself few questions. Can we treat these patients without surgery? Number 2, are these multivessel disease are real multivessel disease, or it appears a multivessel disease and it is either a single or two vessel disease which can be treated with angioplasty? Third thing, if I find it is a critical disease, is there any further way to understand the morphology of the plaque, the calcification in the arteries, what is the extent of disease, what is the real diameter of the blood vessel, and third is, do I need any particular instrument to clean up the blocks first and then and put the stent? And at the end, am I giving justice to the patient? Am I giving the result which is equal to bypass surgery? So these are the questions I ask myself first, and every cardiologist should answer this question to himself first before going for any multivessel angioplasty. So first thing is, are the real triple vessel disease are real triple vessel? Yes. We need to follow it by doing some physiological test, and that is called FFR. So the lesions which are seen on angiography may not be as critical physiologically, and the data is that almost 60 to 70% of the triple vessel disease so-called mentioned on the angiography are not triple vessel disease, and by doing the simple test called fractional flow reserve. What is it? We pass a small catheter with the pressure amplifier on that, and we check the pressure beyond and prior to the block, and that ratio of 0.8 is a magic figure. If the particular ratio is less than 0.8, that block is really significant. If that ratio is more than 0.8, like 0.85, 0.9, these blocks are not critical. So we can rule out many so-called triple vessel disease and convert them into single or double vessel disease, treat those blocks and manage the other non-critical blocks medically. We can follow these patients with the help of newer statins, newer diabetes control medication, and lifestyle changes, diet management, everything comes together, and we can stabilize these patients. So these are some of the examples. It looks like very tight blocks, but they are not right, not very tight. But the one at the bottom is really tight. Do we have any pointer? It's okay. So these are non-critical blocks, but the block which is at the bottom is tightest because it is 0.5. So you need at present treat this block, give good high dose of statins, control the other risk factors, follow these patients, and you may not require anything, or in future if we require something, you can fix that with the angioplasty. And this is a simple cath lab test. Through the catheter we pass this wire and check the ratio. Then comes the imaging. When I see that there are multiple, say 2 blocks or maybe 3 blocks in a 60-year-old diabetic patients, we insist them to go for bypass surgery because we give them option. But if they deny, then I need some further imaging, and that is coronary imaging. There are 2 types of coronary imaging available. One is OCT, optical coherence tomography, where we pass a small catheter. With the help of that ultraviolet rays, it catches the image and reproduces the image. And how it looks like. This is the post-angioplasty patient. You can see the stent which is deployed. You can see the edges of the stent. Is the stent properly deployed or not? Is there any dissection? Is there any injury to the vessel? Is there any hematoma? All these things are easily viewed. This is a stent view. You can see the side of guide wire coming out of it. You can see the side branch. And these are the morphologies we see. There is hematoma, deep calcification, superficial calcification, thrombus, malposition stent, maladapose stent. All these findings can be evaluated on doing OCT, which is a simple test with the help of a catheter, and we push contrast, and there is a pullback, automatic pullback, and we can get all the information and we can give the best result to the patient. Similarly, I don't go into deep. There are some important things. What we see here, if we find that the calcium is more than 0.5 millimeter thick, if the calcification is more than 5 millimeter long, and if it is involving the 50% of the lumen, that is 180-degree arc, these are the cases where we need some special atherectomy devices like rotablation, orbital atherectomy, laser therapy, or intravascular lithotripsy. So this patient had a LED diagonal lesion, and on OCT we found lipid-rich plaque at the bifurcation, and post-angioplasty this was the result. And this is how the stents are seen on the OCT. It is from proximal to distal. You can see this marker. You can see this lumen here. As the stent approaches, you can see the stent struts. Little bit of malapposition which was fixed with the high pressure dilatation. You can see the side branch coming, another side branch here. So this is how OCT gives us information about sizing of the vessel, sizing and morphology of the plaque, and whether the stent placement is perfect or not, whether there are any dissection, whether the stent is apposed or not. Even side branch also can be seen like this. If it is a large diagonal coming out of the LED, you can access this LED diagonal bifurcation later if the patient develops further lesion. Intravascular ultrasound is a similar investigation where we don't need a contrast medium. Patients who have left main disease, high calcification, or patient who have renal failure, this is the investigation of choice for the imaging of the coronary arteries. And this is how the normal artery seen on IVUS, lipid-rich plaque, eccentric fibrous plaque, calcification, stents, all these things, information we can get on intravascular ultrasound. This patient had multiple stents in left system and a very tight lesion in the right coronary. which was fixed. This is the initial assessment. The areas were like 2.5 millimeter square, and post-stent the areas have grown to 4.2, 5.4, 5, 8.2 in the proximal and distal regions. You can see the artery is fixed very, and with the intravascular ultrasound, you can see the adequacy of procedure, whether the stent is deployed properly or not. All this information helps in having good long-term prognosis in such patients. If we treat this patient inadvertently, not apposing the stent properly, not giving the equal size of the vessel, these patients may come back with the in-stent restenosis in a short time. Then what modification techniques? If there is a hard calcific plaque, how do we go for it? So we have balloons, non-compliant balloons. There are balloons with the blade, that is called cutting balloon, or there are balloons with the wire, that is called scoring balloons. And then there are high pressure balloons called OPN balloons, which can stand to 40 atmosphere to open the blocks. But some blocks are not really, do not give way to such techniques. So we need rotablation, that is a drilling technique, orbital atherectomy, or a new technique called excimer laser, where there is instant restenosis or high thrombus load, we use such techniques. So rotational atherectomy, we pass a small burr with a diamond edge. Only front side the diamonds are there, back side nothing, and we drill the block with at 140 to 180 revolutions per minute, and it specifically shaves the calcium and doesn't do harm to the soft tissue. This 63-year-old gentleman had a post-bypass patient, had a large diagonal, which was not that time attended by the surgeon, and proximal LED had heavy calcification. Rotational atherectomy to this proximal LED was done, and a stent was deployed with a good result. Sometimes rotational atherectomy may not be adequate in a large vessels or calcified lesions which are having high calcium score, deep calcium, or a calcific nodule. Here the orbital atherectomy is a newer technique where the burr is rotating eccentrically and getting the so this is the orbital atherectomy, where it is revolving in an oblique manner, or and brings the better lumen gain, and especially patients with calcific nodules, where hard calcific junk is at the one place, may not be amenable to rotational atherectomy. Orbital atherectomy takes care of it, similar to rotational atherectomy. This patient had a LED blocked and a stent, and then we did the rotational atherectomy, orbital atherectomy with a good result. Some patients have very dense calcium, superficial calcium, deep calcium, long calcium, and not even the rotablation may be high risk because of the left ventricular dysfunction, or the chances of slow flow or no reflow. Shockwave therapies, this is something which we bought from our urologist friend. They use the lithotripsy technique for breaking the stones. Similarly, we break the calcium with this, but it's a balloon based therapy. It's a balloon where there are emitters which emits the sound waves and creates the pressure at about 40 to 50 atmosphere, and breaks the calcium plates so that the artery becomes more elastic, and then we can put the stent. This is the shockwave device, and this is a catheter, and this is the balloon with the emitters. Initially it used to be 80 pulses, now we are getting 120 pulses in this. And this is the patient who had a very heavy calcification in the mid LED, which was really tough to manage. And then we use simple balloon, did not work. Then it's a intravascular lithotripsy balloon. We exhausted all the 120 pulses, but after that we got a very good result, good lumen gain, and the final result was good. So there are ways how to use and indications which atherectomy device should be used. Too much technical. Similarly, excimer laser. Recently we had one patient who had, I did the angioplasty in 2005, a brother of my close friend, and his artery was not opening with with the help of cutting balloon, with the help of OPN balloon, and we had to take the patient to other hospital, and we did the laser atherectomy. Here the laser atherectomy opens the blocked vessel in a better way, high thrombus load, instant restenosis, all that. Then there are advances in, I don't go into details, advances in techniques where we can give the myocardial salvage. Patients with high risk left main angioplasty or poor left ventricle, we can use intra-aortic balloon pump for the better effectivity of the angioplasty technique and safety. Similarly, impeller device, another pump which can be inserted into heart to protect the muscle and get the angioplasty in a better way. This is the impeller device. Similarly, transcatheter aortic valve replacement has come in a long way, and now in US and European countries, anybody who is more than 70 do not go for surgical aortic valve replacement if he has aortic stenosis, or those who have had previous bypass surgery or previous aortic valve replacement, they straight away go for aortic transcatheter aortic valve replacements. In Manipal Hospital, we have a very robust transcatheter aortic valve replacement programs. Here recently we did two or three wall-in-wall cases, two post-bypass cases where it was very high risk for the patients to go for another surgery, and successfully we completed the aortic valve replacement. Patient was discharged on day 3rd, walking on the day of the procedure itself. So there are two types of valves, balloon expandable and self-expanding valves, depending on the patient's anatomy, patient's femoral artery size, patient's angulation, patient's calcification, coronary heights. These valves are chosen, and accordingly we need to consider the patient's age, patient's lifespan, and this is how we plan the surgery or transcatheter valve replacement requirement for these patients. So this is tower, how it is done, and this is what we have done here. This patient had a very tight aortic stenosis, adequate coronary heights. We have to pace the ventricle at 200 or 250 beats per minute to reduce the cardiac output, and then cross the valve with the balloon dilate it, and then this is the balloon expandable my valve, that is Merrill valve, which was implanted successfully. You can see the heartbeats are going to 200, 220, so that the cardiac output remains minimal, so that there is no movement of the valve at the time of expansion, and the valve is expanded successfully. Coronaries remain patent. There was no aortic regurgitation, no residual significant gradient across the valve. So this is the expanded valve, no AR at all. Coronaries are flowing well. For hypertension, the new technique has come, renal denervation therapy. Patient who is hypertensive for 5 or 10 years on 5 or more medications, still the blood pressure is not controlled. Renal denervation therapy can be used. 1 minute. Renal denervation therapy can be used. Here the simple technique is you go into the renal artery. There are sympathetic and parasympathetic nerve circles all around, and you ablate those, and thereby you can reduce the number of medicines, number of antihypertensive medicines in such patients. So this is the catheter. We pass from the renal artery, from the femoral artery into the renal artery, and multiple ablations are done. The heart failure treatments again come in a long way with the help of newer CRT devices. The left ventricular function, despite of medication, if it is not improving, the CRT, especially in wide LBPP category patients, the resynchronization can be done. This is how the pacemaker is there, and there are 3 leads: atrial lead, ventricular lead, and coronary sinus lead, which can, this is a coronary sinus lead, and we can resynchronize the intervals so as to have best cardiac output. So I go to, this is patient had a poor LV function, and post CRT the LV function has improved almost like 45 to 50%. So it was a big topic. I tried to jump into the slides. So I think it got happened. So in short, these newer advances in cardiology, interventional cardiology, given us so many new avenues to treat these patients who are at high high risk for surgery or who have multivessel disease at a young age. And with the help of newer antiplatelet drugs like ticagrelor, newer statins or newer lipid lowering drugs, we can safely treat these patients with non-surgical ways also. Thank you so much for patient listening.